I'm going to review for you some important aspects of pigmented skin lesions. And the key with these is there are some that can certainly be very safely and successfully treated with lasers and some other treatments as well. But there are some that you need to be aware of can be pigment cancers such as melanoma, where you really, if in doubt, need to refer on for further examination. So let's go to the next slide, Haley. Yeah.
Yeah.
That's the introduction. So as I've said, this is just a summary. What we'll try and do is to identify some of the common and different pigmented lesions that you'll see in your practices. Try and get a guideline, produce a guideline to what are the suspicious lesions where you need to refer on, and often skin biopsies and special dermoscopic examinations are needed. Those that can be treated successfully, what are the best ways of treating them, when to treat and when not to treat is actually basically what I'm going to just review in this talk. So the next slide should be the 4 pictures of some different pigmented lesions.
Yeah.
And the face on the top left is what we call a benign lentigo or solar lentigo. And that's the common so-called age spot. And if you look at that, you can see that it's relatively uniform in color. The outline is irregular, and I'll come back onto that in a moment, but because of the uniformity of color, this is almost certainly a benign lentigo and can be treated with a laser. The one on the right are a number of different lesions, and they're a combination of pigmented benign nevi, but moles, but there is one in the center there that does look a little atypical. If you look, it stands out a little bit more rather than the others. It's a darker color. The color is slightly irregular. So that might be one that should be referred. The bottom left is definitely an atypical, irregularly pigmented, different colors. You've got red, brown, and black. And that is almost certainly a malignant melanoma. And then the one on the lower right, which is shows a considerable amount of sun damage, photo damage, with a lot of abnormal pigments, scale, etc. They are a combination of what we call benign pigmented seborrheic keratoses and another group of solar keratoses. So that's sort of some of the more common, but fortunately the melanoma is less common, but certainly common enough to be of great importance to recognize. Next slide. And how does pigment actually form in the skin? The basal cell layer of the epidermis contains melanocytes, which produce pigment. In all skin types, interestingly, whether they're very dark skin of color, black skin, Asian skin, Caucasian skin, even redheads, there's one melanocyte to every 10 keratinocytes. So there's always that 1 in 10 ratio. And the reason that you get different colored skin, different intensities of color, is that the pigment is able to be more efficiently transferred to the other keratinocytes, for example, in black skin. The darker black skin is much more efficient than Caucasian skin at producing pigment, because it packages the pigment more efficiently in melanosomes, and it transfers the pigment much more efficiently into keratinocytes. So that's basically why the different skin phototypes occur. And what we think happens with sun damage is that there's local areas of genetic damage to the cells that then are programmed to incorporate more melanin and transfer more melanin into the neighboring keratinocytes that then produces the brown spots and sunspots that we know as lentigo, freckles, birthmarks. Birthmarks often, of course, are programmed themselves to produce more intense pigment. So that's basically a broad overview of how pigment produces in the skin. So the next slide is an important one, and look at, if you're seeing somebody that you may have brown patches on their skin, and certainly we'll look at some of the more common ones, but what do you actually look for to make sure that it may or may not be cancerous? And it's basically the A, B, C, D, and E signs. E, I think, is important. Any recent, the other thing is any recent change. So if there's been a recent change, whether it be crusting, scabbing, bleeding, sudden darkening, even sudden lightening, that should raise your suspicions. If it's a gradual change, it's usually, but not always, benign. The shape of the outline of the lesions, is it asymmetrical? That's not always the case. Asymmetry can certainly be present, as I showed you in lentigo. But are the borders even? Do they sort of spread out? Are they indistinct? If the borders are spreading out, if they're not quite distinct, that's another clue you may be dealing with a skin cancer, a melanoma. When you've got multiple colors, as one of the ones I showed you before, that's another clue that you may be dealing with a melanoma. Small lesions in general, the size of a pencil head, are generally benign. That's not always the case. And in fact, if you've got other features with the irregular colors, etc., in a very small lesion, it is worth sending on. And then the change in shape, color, and size, all of those, crusting, scabbing, change of color, redness, bleeding, all of those things can be a clue that you're getting a change into a malignancy. One of the other misconceptions is that you have to have a mole to develop a melanoma. You actually don't. Some melanomas arise, what we call de novo, arise by themselves without being in a previous mole. And a suddenly appearing mole is again something to be suspicious about. So let's go on to the next slide. So what are some of the things that we can treat? Well, this is the most common type. This should be solar lentigo on this slide. And these are round, well demarcated, usually a uniform color, surrounded by normal skin. There's usually no redness or inflammation. They're always on the sun-exposed skin, so head, neck, and hands, forearms often, lower legs in women, particularly if they have worn shorts, etc. The great majority of people will get some form of solar lentigo over the age of 60. And you do get, on biopsies, you do get increased melanocytes, you also get increased melanin transfer. And they're distinct from freckling. Freckling, which I think many of us are familiar with, most commonly in redheads, but also in fair-haired individuals, will darken on exposure to sunlight. Lentigo tends to remain the same, although it's interesting, lentigos often show up more when the surrounding skin is paler. So ironically, lentigos sometimes are more obvious, certainly on Caucasian skin, that tans during the winter months when the surrounding skin is paler. And that's often when patients come in to be concerned about wanting them treated. So let's go on to the next slide, which should just illustrate a number of the different pigmented lesions that can be considered for treatment with lasers. So freckling, the trouble with treating freckling, and there are some patients who do have a lot of emotional problems with having lots of freckles. You can certainly treat them with, for example, the ruby, the alexandrite, the ND-YAG, or even the pulse light, and you will get some fading, but they generally always come back with time. And so I try and reassure them that their freckles are normal, but those that do want to be treated certainly can be, and you can lighten them with those different treatments. Lentigo, you certainly can. Caffeole macules, these brown birthmark type flat darker brown spots, again, they can be treated, but they will often come back. Becker's nevus is a nevus which is basically pigment plus hair growth. It's a benign, hairy, pigmented nevus. So any nevus that, any dark congenital area that's got increased hair growth is what is known as a Becker's nevus. That's often, if you're treating those, we will often use both the hair removal laser settings as well as, in combination, some of the pigment settings, for example, the Alex and the Ruby and the ND-YAG. Seborrheic keratoses, in my opinion, are best treated with some form of ablative treatment, either a targeted ablative CO2 or cryotherapy, or sometimes some of the pinpoint stronger peels. But caution is needed not to cause hypopigmentation. And actinic keratoses we'll come on to in a little bit. There's a variety of different treatments there. And then a variety of different benign dermal pigment we'll talk about later. Some rare conditions, the if you will, the oriental or Asian pigmented lesions, the nevus of Ota or Ito, some benign nevi, blue nevi, and obviously pigmenting tattoos. You have to be careful with tattoos, which is certainly a subject of a much longer webinar, but some colors don't do well. Indeed, yellow tattoo may darken paradoxically with some of the pigment lasers. So be careful, and if they've had dark tattoo overlying yellow, you may be causing problems with darkening. Post-inflammatory hyperpigmentation usually requires combination treatments with skin lighteners as well as some lasers and peels. Melasma similarly. Nevus spilus, I look on that very similarly to what I talked about with freckling. And then should we or should we not treat any in situ skin cancers? My opinion is not, and they are the ones to refer. And we'll talk as we go through which to use the pulse lights, which to use the pigment lasers on. So there we go. Next slide is just to remind me what I've just said. Don't use lasers for malignant lesions or suspected malignant lesions. Otherwise, you can conceal them, you can suppress them, and the abnormal, the malignant melanoma can then be actually spreading without either the patient's or the physician's knowledge. So what are some of the important lasers?
Sorry to interrupt you, Nick, but that's quite an important point, I guess, isn't it? I mean, I probably wasn't aware that it's not the case that you could make it worse, anything that your laser will do to increase the chances of you having that or accelerating that melanoma. It's just that no one else will be able to see it as well in it. So someone else that could have had the opportunity to diagnose it now can't, because we've actually got rid of the pigment in it.
Yeah, that's great, Hayley, to point that out. In fact, come in and join in, and so it stimulates me to think about things as I go along. Yeah, that's a very important point. If you treat a pigmented nevus with a laser, If it's a benign pigmented lesion, if it's the right laser, the right settings, you will lighten that pigmented nevus, but you will modify it as well. And so that doesn't matter if it's a benign nevus, and there's no evidence that I'm aware of in the literature that treating a benign nevus with a pigmented laser increases the risk of turning malignant. There's no evidence for that. But if you're treating an atypical nevus that's starting to turn, or an early melanoma, you can disguise the changes that allow us to identify that melanoma. So that's one of the main risks. And so that's one of the main reasons why we don't want anybody to be treated that has what we call an atypical mole that has a higher risk of going into a melanoma or a true early melanoma, is because you can change the appearances when you look at it. You can change the appearances under the dermoscope, which, as you probably all know, is a special instrument. The dermatologists look at a very ultra magnifying picture of pigment lesions. And then finally, if even under the microscope, when you take a skin biopsy of something that's been treated, a lesion that's been treated with a laser, that can look atypical. So those are all reasons why, if in doubt, don't treat.
And can I ask another question actually as well? So at Linton, we say that if somebody has a history of any form of skin cancer, that they're contraindicated to all laser treatment. I think that we have to be sort of quite strict in the guidelines and the rules that we give. I'm just interested to know, do you treat people that in the past have had skin cancer, or do you contraindicate that as well?
Well, I think that the right way to, and I agree with what your advice is. I think the advice is that those patients can be treated by a dermatologist, but only after we've gone over the whole patients with a fine tooth comb and a dermoscope to examine every area. And certainly I will treat patients, for example, that have had actinic keratoses or a basal cell cancer in one part of the skin, and they've got multiple areas of photo damage or lentigo, for example, on the face, but only after a very, very careful full skin examination with dermoscopy. So I think for most practitioners, refer that type of patient with a history of skin cancer.
Yeah.
Skin cancer history means that they have a higher risk of melanoma. It is one of those increasing what we call comorbidities. Okay.
Okay, yeah, great, perfect. So we're on to our lasers for pigment slide now, Nick.
Yeah, and I used one of the very early Q-switched ruby lasers way back for treating originally tattoos and hair removal. So I must have started that about 30 odd years ago. And the very first laser I ever used was the second one available in the United States of the pulse dye lasers that is now used routinely for birthmarks and telangiectasia. So yeah, the Q-switch lasers are extremely valuable, and the wavelengths of the lasers that are selected are the ones that are most absorbed by pigment, and they include the Alexandrite laser, the ND-YAG laser, the old ruby laser. There's still quite a few of those around. And then we can use what we call non-selective lasers to reduce pigment, which include the carbon dioxide laser, fragmented fractional carbon dioxide lasers, very useful. There's a few other wavelengths as well that can be used with a fractional laser, such as a 1550 nanometer one. But then the other very useful group of products are the intense pulse lights. And they've really come to the fore because by selection of the parameters with the specifically the different filters, as well as the different pulse durations, you can get really excellent results with the pulse lights. They're not lasers and they're not Q-switch. They tend to be longer pulsed in duration, but they are extremely valuable. So let's go on to the next one there. So this type of lesion, which is the solar lentigo that we saw earlier in close-up, it's relatively uniform in color. It's a little bit irregular, but not too irregular in outline. And in addition to the larger one that she's got at the right eye, you can see lots of little ones scattered. So this is a sort of patient that I will frequently treat by targeting the darker lesion with the Alexandrite laser, and I will either use the long pulsed or the Q-switched Alexandrite or Nd:YAG laser, and then to the whole face, and she will do very well, and she has actually improved and with the intense pulse light. So I'll get a more focused, more rapid improvement with the pigment Alexandrite Nd:YAG and or long pulsed or Q-switched, and then treating the whole face with the IPL. You will get a significant improvement with the larger lentigo with IPL, but sometimes it does need a little extra help. Don't forget with IPL, as I'm sure most of you know, you do need to do several different treatment sessions, usually a minimum of 4 to get the optimum improvement. The other thing that we haven't said, and we will do a bit later, is what about skin phototypes? This patient, I would say, is a phototype 2, but if you're dealing with darker skin phototypes 3, 4, etc., you have to be extremely careful with using any lasers or pulse lights. Often these need to be, you can treat some of them, but you need to be very careful, and you should always do a small treatment area first. So we haven't got a slide in talking about which phototypes to treat, but in general, it's skins 1, 2, and some 3s, but do be careful with the 3s and darker. If you're going to treat, this includes hair removal, etc., do a test treatment first, making sure you're not producing hypopigmentation with your laser. Next slide.
Nick, just before we move on, there's an interesting question from the audience just on whether you would start with this first by using topicals or whether you'd go straight to laser or IPL.
Yeah, I'm sorry, I should have mentioned that. I will always view these, and there's a slide further down, but good anticipated question. The answer is, with anybody who's got a pigmented area, particularly solar lentigo, anything to do with photo damage, it's you must always think of holistically combining treatments, and that includes daily sun protection, the use of appropriate skin lightening creams, which either can be prescription strength or non-prescription strength. You can even alternate and combine somebody with photo damage and multiple lentigos by alternating pulse light, lasers, and indeed things like appropriate peels. So yes, you've got to treat them as well. And my advice to all the patients is that if you are wanting to have your lentigo treated on a sun-exposed area, you're wasting your time and money treating them if you don't agree to a sensible sun protection, skin lightening, home treatment program. Okay?
Yeah.
We can talk about that a bit more. There's a slide coming up when we talk about melasma. So yeah, the next slide, solar lentigo, another example, multiple lesions. And this is an ideal patient again who was treated, I think, with IPL, intense pulse light. You can see there's a few little areas still remaining. And if this were at the end of, say, 4 treatment sessions with the pulse light, I would just go back if she wanted to and target these extra areas. The other thing that she's a good candidate for is one of the vascular lasers, because she's got a little bit of telangiectasia on her nose, but you've got less telangiectasia, and again, it illustrates after treatment how the pulse light can actually improve telangiectasia. So I think that's a useful slide. Okay, next slide is again a slightly more one. This is from Dr. Gonzalez, but this is the type of patient that I would definitely treat with a combination of topical therapy. I'd pre-treat with tretinoin, skin lightening creams, ideally for at least 6 to 8 weeks before the laser, photo protection every morning, get them into that habit. And then in this type of patient where you've got a benign solar lentigos on her face, on her cheeks, and you've got scattered areas of photo damage elsewhere, I would see as an ideal candidate for a fractional carbon dioxide laser. In addition, I might also, at that first session, treat with a Q-switched or long pulsed alexandrite laser to the pigmented areas. So she's an ideal candidate, and you can see the improvement with not only the pigment, but also the wrinkling and the photo damage. She's also a great candidate for adding in some botulinum toxin and appropriate fillers. And that's very safe to do both before and after laser treatment. So next slide. Another ideal candidate to consider, there's just a small number of these benign solar lentigo. So you can see that they rapidly respond with the targeted laser, either the alexandrite laser. Again, I often will use the long pulsed mode as well as the Q-switch mode. My impression is, and I think there needs to be more studies, is whether you get a longer lasting improvement with the longer pulsed than the Q-switch, but they're very useful both ways. And you will get, this last one was 1 week after, you will get some progressively more improvement. And the dorsal hands, patients often forget that they need to put sunscreen on the hands even when they're driving their car, because long wave ultraviolet comes through car windows and will darken it up. Seborrheic keratoses, the most common of all non-photo damaged, non-sun exposed benign skin lesions. They're a benign, what we call a hamartoma. They're a proliferation and overgrowth of keratinocytes, of the epidermal keratinocyte. We don't know why they occur, presumably some local abnormality of growth factor. They're not always highest in sun-exposed skin. You often get many, many of them on the trunk of patients who also have them on the face, but they're often increased pigment on sun-exposed skin, and they usually rarely go away unless they are irritated. Some of the patients who have a lot of seborrheic keratoses will actually scratch them with a little bit of sandpaper on their nails, and some inflammatory reaction will often clear them. So they can occasionally resolve, and they will occasionally present with that question that I had this dark spot and it's gone. Help, is it a cancer? So that's very common. Next slide. And this is certainly a favorite treatment that I will use, and I will use the carbon dioxide laser in a targeted ablative mode, very lightly, just to create enough thermal injury that the seborrheic keratosis lifts off. Many other treatments for seborrheic keratoses, cryotherapy, curettage, scraping, etc., etc. You can slow some of the new ones down by treating the whole area with a topical retinoid cream or gel. So those are all things. And you can also, once you've treated them. And again, I think when you're using ablative lasers, this is really for somebody, physician who's very skilled with that particular laser. Otherwise, you can certainly over-treat and cause hypopigmentation and scarring. But once you've got an improvement of the larger ones, if you look at the right-hand photograph, you can see closely some very early remaining ones. I would go over that whole area with a relatively low density fractional CO2 to try and reduce new ones forming.
We have a couple of questions, Nick, if I can just go through some of these. So question about, could you use plasma pen on this?
Yes, I'm sorry, that's another option. We've been looking at the plasma systems in our clinic, and I would have to say I am not switching away from my local ablative CO2. I don't believe they're any faster. If you produce enough injury, if you will, controlled injury to get rid of the seborrheic keratoses, the healing time is very similar to the appropriate setting with a locally ablative CO2. So I'm aware of the work being done. We have one of the experimental plasma systems and have had for some time, and I'm as yet haven't been sufficiently convinced to buy it, but I may be proven wrong.
And I think there was a question about the anesthetic that you use as well.
Yeah, anesthetic. If they're very small lesions, you can get away with something like the Elemax cream or one of the formulated local anesthetic creams, putting them often under a saran wrap, tegaderm dressing to aid penetration to a local area, wait 30 minutes or an hour, and then use the ablative CO2. If they're larger lesions, I will inject local lidocaine, xylocaine mixtures.
Do you have a preference on your local anesthetic?
Not really, no. I'll obviously inquire for local anesthetic creams. As I say, the Elemax is very good. We'll get the pharmacy to formulate a high concentration of tetracaine, lidocaine. And then as regards the, I'll often use xylocaine, lidocaine 2%, and occasionally if it's a large lesion, I'll use them with added adrenaline.
Great.
Sometimes if there are a large number in an area like this, I might do a very local dilute tumescent xylocaine, lidocaine infusion.
Perfect, thank you.
Okay.
Also, there's just a question regarding the so fractional erbium on SebK.
Yeah, that can work. Fractional erbium can work very well. You don't get quite the same hemostasis that you do with the CO2, but certainly you get a nice result. And gentle fractional erbium is very successful. As I say, fractional systems are very good if you've got multiple small seborrheic keratoses. If you've got larger ones, you need to use some ablation.
Great.
Okay, so the next one should be a bit more on actinic keratoses. Those of us, I mean, the only reason, having lived for many, many years in Southern California, the only reason I've not got any actinic keratoses is because I've also got a photosensitive problem called polymorphous light eruption. So I've had to use sunscreens most of my adult life. But anybody that lives in a sunny climate, and more people with sunny holidays will have actinic keratoses. And then these can range in severity from being relatively mild, often very faint scaling erythematous, to much more thickened hyperkeratotic lesions. They certainly can proceed to squamous cell cancers, and it depends on the amount of sunlight you've had. Certainly in areas and in parts of the skin where you've had a lot of sun exposure, in fair-haired individuals, you can actually get up to about a 14% risk of actinic keratoses going into skin cancers. And so it is important that these patients are examined carefully. Males more common than females, simply, I think, because we have less hair to protect our faces, but also males tend to ignore the advice of doctors. They tend not to put on sunscreen. They don't tend not to wear hats. So I think more sun exposure. What I've put down at the bottom is there are several treatment options for actinic keratoses, and this is where, again, I will combine other treatments, sun protective creams every day to expose skin. There's some very good prescription products that can reduce the incidence of new keratoses, such as Solarase cream. Some of the peels are very effective, salicylic acid peels, if they're multiple areas. Obviously, the old-fashioned fluorouracil cream, which has its good as well as bad points, the bad points being severe inflammation. And then lasers, both ablative as well as non-ablative. And then finally, photodynamic therapy. It can be excellent where you've got actinic keratoses over a large area. And this next slide shows somebody who's been treated with a fairly aggressive, higher density CO2, which has produced a nice result. He'd probably need another extra treatment, but this is the sort of patient that I will have on long-term Solarase gel at night, alternating with a retinoid gel at night, one night one, not one night the other, and every morning broad spectrum sunscreen. And you will get good involution there and maintenance. And obviously you can retreat regularly every year or 2 years with the appropriate fractional laser. Very successful. Now, the next slide is what we try and prevent happening, and that's where you've got a superficial or atypical lentigo that has been allowed to spread, in this instance, across the forehead. And this is where you've got to be very careful of treating solar lentigo. Some solar lentigo lesions, if they're suspicious at all, if they're irregular in color, I will always elect to take a very superficial biopsy. Often it's the one area at a time. I think that shave biopsies are extremely valuable, done by a dermatologist who looks carefully, and I'll take a very superficial sampling, and if it's not it's not gone into a lentigo melanoma, it avoids having sutures or stitches, and you can then treat it with minimizing risk of scarring. But these are often very difficult patients to treat. Certainly, wide excision can sometimes be extremely problematic with grafting. So the secret here is try and prevent it in the first place by identifying it early when these are small. Some of the other things that can be used and has been shown to contain some of the certainly less aggressive lentigo, superficial lentigo is Aldara cream. Its chemical name is imiquimod, and that can be very successful. But again, these patients clearly need to be under the care of a dermatologist. Next slide. Hyperpigmentation, very common, and this would be a skin phototype 4 patient. Very common Asian patients have post-inflammatory hyperpigmentation after acne. And I think combining topical treatments with skin lighteners, tretinoin, and sunscreens in the morning are vital to get started with. But sometimes when you're left with this rather distinct local areas, the careful testing with a Alexandrite laser is appropriate. I think here the pigment-specific lasers, rather than the pulse lights, are a little more safer, and we can focus them more. I have had some success where you've got a lot of post-inflammatory hyperpigmentation, where you've had a lot of post-acne pigmented scarring, for example. We'll often use the fractional systems, low density, non-ablative, fractional, longer wavelength lasers, and also appropriate chemical peels, but very gentle. The secret here is go gently and repeat treatments. Café au lait lesions, yeah, go ahead.
Sorry to interrupt you, but do you, with post-inflammatory hyperpigmentation, do you sort of have a certain amount of time that somebody would need to be on a lightening agent before you'll go ahead and perform any kind of treatment?
I think it's worthwhile with anybody that you're pre-treating with lightening creams and getting them onto sunscreens and topical retin-A, retinols, at least 2 to 3 months.
Yeah, and you mentioned Alexandrite, Q-switch or long pulsed?
Well, you can try either. Again, this is one because I find that a relatively low energy with the long pulsed can be quite successful. But again, I would try either. And if the pigment is deeper, I might even do a test with the ND-YAG. But I think this is one. Yeah, this is one.
YAG, don't you?
Yeah, this is one where you need to, I think, refer probably.
We contraindicate this actually. So if there are any Linton customers in the audience, you might be thinking, why have Linton told me not to treat this? And it's because there's just a high, if someone's hyperpigmented, you know, there's a risk that you know, anything that you do could cause more of that to happen.
Yeah, I will have often had patients that have been referred on from other areas, other clinics. So they'll have tried a number of different things. So I will I'll be quite cautionary with the patient, saying that we may be able to improve it. We will do get you started on the home treatments first, and then to test very carefully with appropriate laser.
Yeah. So I think if you're in the audience and
very unpredictable.
Very unpredictable. Yeah, definitely.
That's best to refer.
If you're in the audience and you're a medic, if you're a dermatologist, for example, then we are happy for you to do these treatments on this post-inflammatory hyperpigmentation. If you're not, then we actually do say just don't bother, because you know you could end up going down a road with a patient where, as Nick says, it's very unpredictable. You end up making it worse. So just refer them on. And if you're not sure who to refer to, you can always just speak to Linton, and we'll advise of somebody that's maybe, you know, outside of your geographical area, you know, someone like Nick that you can refer these patients to if you want to make sure that you send them on to somebody that's got, you know, a good range of equipment. There's a question from the audience just on treating PIH with IPL on a very light skin. So would you say it's different when you have a skin type 1 and 2?
Yeah, I mean, I think it is. Put it this way, you get greater success with skin types 1 and 2. Again, the problem is with the IPL, unless you've got something that you've got a very small spot size, that can be a little bit difficult. And you can get square or rectangular changes that are not very easy to blend in. So we tend not to use IPLs for post-inflammatory hyper. Okay.
So we do have this applicator. I don't know if you're able to see me. I seem to have spent a few webinars talking about this block for our IPL. So this is a very, very, very small IPL applicator that's circular. So
yeah, if you've got that one of those nice applicators, certainly I wouldn't have any problem in doing a test treatment. But I think definitely I would say a physician that's used to treating hyperpigmentation and going through all the necessary warnings to the patient. Yeah.
I think it's this is actually quite a nice one for you to use for all your pigment. So what Nick's saying there is, you know, often these solar lentigos or freckles that we may be treating are quite round. So if your device has a square applicator, it can be quite tricky actually to get that well covered. Whereas with a nice round, small, tiny applicator like this, that just works quite well. So I just thought I'd point that out.
Yeah, no, that's great. Thanks, Hayley. The next one, caphio lesions, they often really, by definition, they occur usually in childhood, always in childhood, quite frequent. There's a small association in very few patients with neurofibromatosis. Again, if in doubt, if you think there's anything else, if somebody with multiple neurofibromas, they should be referred to a dermatologist for evaluation. They never become cancers, so that is a good thing. If you go on to the next slide, and you can get definitely some good improvement using appropriate lasers, in this instance an ND-YAG, certainly the long or Q-switched alexandrite, and certainly in some instances the pulse light with appropriate pigment filters. So this can be actually quite successful. Interestingly, in this guy, you've not got rid of his freckles, but you have got rid of most of his caphio-lay lesions. So that's actually very successful. This is the next slide is a relatively rare condition in this country. It's much more common in the Asian patients. I do see quite a number of patients. In fact, we wrote up a paper some years ago on success with the Q-switched alexandrite laser, and so you can treat them with either the Q-switched ND-YAG or the Q-switched Alex, and you can get really nice improvement. It's rare that you get melanoma, and they're usually very benign lesions. If you go on to the next slide, this is this typical very light gray pigmented areas, often some background erythema in Asian patients. Some Hispanic patients, I used to see quite a lot in Southern California in the Hispanic community there. So it's not just Asian patients. So interesting patients, and this is the point of another webinar indeed, but it's when I was treating a series of patients. If you look at this one on her left, she's got those dark circles as part of her nevus aorta under the right eye. And we noticed that we could really improve that with nevus aorta. And it led to us doing some research on treatment of dark circles, but I've not got time to go into that now. But interesting, another aside. Very much more common condition. The next slide is melasma, and it's these patches of pigmentation, usually on the face, occasionally on the neck, always related to having taken the contraceptive pill, having had pregnancies. It's an estrogen stimulus, and it can be patchy, it can be widespread, and it's very typical and very frequent. More commonly in darker skin phototypes, as the next slide shows. And often, interestingly, it's not just sunlight that causes it. It's now known that it's visible light and indeed heat. Infrared can actually increase melasma. Next slide. The treatment is very important to be, it's a multiple treatment approach. the patients have to be warned that there is a problem with repigmentation, and so sunscreen every day is essential, and I will use reflecting as well as absorbing sunscreens on the patients. We'll use skin lightening products, including hydroquinone, niacinamide, alternating often with retinols and tretinoin. Azelaic acid is another good product that can decrease skin pigmentation, and repeat chemical peels. Next slide. If you've got, however, localized, well demarcated melasma, as in this case, you can use certainly the pulse lights. And what we'll often do is go very cautiously, do a test area, and I will often in this patient pre-treat with a skin lightening, and then I will also start using chemical peels alternating with IPL. So 2 weeks ahead, I'll do the peel. 2 weeks later, I'll do the IPL, back to the peel, back to the IPL. And if they're religious about using their skin lightening, you can also get progressive lightening. That they will repigment if they don't protect, and they often forget and stop using the skin lightening and the sunscreens in the winter, and they will then repigment with the UVA present in the winter. And then the other thing that's being used now, and I've used this for several years, is oral tranexamic acid, which is an estrogen blocker, which used to be used for menorrhagia, heavy menstrual periods. This can also help to block the estrogen effects on the pigment cells. So it's a multifactorial treatment, and I will say there isn't a cure. There is ongoing treatment that you may wish to continue with. You may get bored with it. Interestingly, later on in life, postmenopausal women, you will get often a progressive lightening of their melasma. And then the last slide is conclusions. So you got many, this is just some of the options, some of the targets that you can use to treat with lasers. Extra caution in darker skin types when you're using any laser, but particularly when you're treating pigment disorders. Test areas are usually required, in my opinion. For pigmented lesions, we've talked about the risk of missing a melanoma. Always advise daily protection as well as appropriate skin lightening products, and then if in doubt, refer.
Yeah.
And that's the last slide.
Perfect. That was fantastic, Nick. Thank you so much for that so far. We've had lots of audience engagement all the way through that. And there's a couple of sort of last questions and some interesting discussion areas to just get into. One of the questions just here is, do they continue using the skin lighteners during treatment? So I'm guessing that's for melasma. Do you keep them on the lighteners all the way through? Yes, they do. Absolutely. And there's no need even to stop the Retin-A. Some people say stop the Retin-A a week or so before a treatment. I don't believe that's necessary. And in fact, if you're treating them regularly, you need to, that's a buzz that I've got something in about 2 or 3 minutes. Okay. So the answer is yes, you keep going with them, and you can restart the skin lightening literally the next night. Yeah. Right, Nick, there's one question which I won't be able to answer, so if we can ask you that, and then we'll let you go, and I'll try and finish up any other questions that are in the audience. So how long do you continue the oral tranexamic acid tablets for, and do you use a topical tranexamic acid cream? Do they work? I'm not convinced that topicals have been sufficiently proven. There are lots of people that are promoting it, lots of companies, there are few companies that are promoting it. I'm waiting to be found out. I don't think they do any harm, so you can certainly try it.
Some have got tranexamic acid and other skin lighteners like azelaic acid mixed together, and that's fine. I would, any skin lightener, as I say, we continue with it. Oral tranexamic acid, I'll start at the first consultation. I always use full consents. There is a small risk of historical risk of deep vein thromboses, but we haven't seen any as yet, touch wood, but that is something to be aware of. They'll start and they'll continue right through the course of treatment. And once they've got maximum improvement, I'll then stop it.
All right, super. That's brilliant. Well, thank you very much, Nick. That was fantastic. Sorry we did get off to a bit of a delayed start, but that worked really well.
Yeah, well, if we can, we'll get our Zoom sorted somehow.
Yeah, we'll just use it tomorrow and it'll be fine.
Yeah, it probably will. It was fine with one of my sessions earlier on, so I don't know what's happened. Yeah.
Well, thanks so much for persevering, and thanks for your time today. That's
great. And we'll touch base, and thanks everybody for their attention. Thank you.
Thank you.
Bye.
Thanks. Bye, Nick. Bye.